Thanks everyone for joining. Good afternoon and welcome to this Merative webinar. This is your 2024 Benefits Program Blueprint, where our panel of Analytic Advisors will walk you through their analysis of the latest trends in GLP-1 drugs, price transparency, and oncology. All right, quick word about Merative before we get started. I think most of the folks on this call likely know who we are, but for those who might not, we have been a trusted partner in the healthcare analytics space for over 40 years. You might have known Merative by one of the previous names you see here on this slide. And today we serve more than 40% of the Fortune 100, 7 of the top 10 US health plans, and more than 70 state, local, and federal government agencies. So we work with clients in a variety of ways to address their needs across health and benefits programs. And you see some of the examples there on the right side of the screen here. So whether it's trying to improve population health or member experience, or address program cost and performance, meet regulatory requirements, increase quality measures. There's really a lot that we can help clients do. And as you can see here, a wide range of solutions in our portfolio to help address those needs. And really the key idea here is that we stay flexible to meet clients where they are. So some do look to us for more of a full end-to-end analytic solution, such as Health Insights, that provides everything from the data warehousing, data cleansing and aggregation, advanced methodologies, benchmarks, predictive models to enhance data, as well as the dashboards and tools to analyze it and draw important insights. Other clients just want to license methodologies and data, and so we work with clients flexibly to deliver what they need across the board. So the reason to share all that background is just to provide context for today's presentation. Our presenters today, and they'll introduce themselves as they cover their content. Each of them are members of our consulting and thought leadership team. And they are some of the people who work directly with our clients to help make sense of their data and help them make smarter program decisions to support their business goals. So, really a story here, more than just a software vendor, but a strategic and consultative partner to our customers. So I think that's enough background. I'm going to turn things over now to Catherine Shanahan, who will kick off our discussion on GLP-1s and weight loss drug trends. So you can take it away, Catherine.
Thanks, Manny. So hi, everyone. I'm Catherine Shanahan. I'm our Senior Pharmacy Analytic Advisor here at Merative. My background's in pharmacology, toxicology, research pharmacy, drug development, but I've spent the last decade working with payers, with commercial government health plans, large employers, research groups on drug-related analytics, identifying opportunities to improve benefit offerings, healthcare access, affordability, and quality of care. The first topic for today's Benefit Program Blueprint webinar is GLP-1 medications. We know this is a very important topic to all of you as utilization and spend on GLP-1 medications continues to climb and payers are looking for increasingly opportunities to manage patients and measure outcomes. But before we jump into GLP-1s, I'd like to quickly talk about MarketScan. Merative's MarketScan is one of the largest and longest running US claims databases used for healthcare research, representing 37 billion records, 293 million patient lives, and over 2,400 journal articles have been published using MarketScan. Throughout today's call, you'll hear various analytics that will run using MarketScan data. Many of you here are familiar with MarketScan benchmarks and Health Insights, but there are a number of uses of MarketScan data. For example, MarketScan Workspace is now cloud-based and supported by Snowflake, which provides quick and easy access to MarketScan data without having to pull down lots of large data files. Or Treatment Pathways, a massively powerful and easy-to-use visual interface that sits on top of MarketScan, allowing you to pull insights and benchmarks really easily. We probably could spend the entire call talking about MarketScan, but just for our current healthcare Health Insights clients, if there are particular analyses in today's webinar that you would like to repeat for your population, I encourage you to reach out to your account teams to learn how. Everything that you see today, a lot of the stuff that we are pulling from MarketScan that you have access to. And others are interested in learning more about MarketScan and what we have contact information later on in the presentation. But with that, let's jump in. So despite their rise to fame recently, GLP-1 medications are not a new drug class. The oldest GLP-1s, like Victoza and Trulicity, have been on the market for upwards of 10 years now, and in fact are nearing the end of their patent life. However, recent years, a number of highly effective GLP-1s have entered the market and expanded beyond diabetes, for which GLP-1s were originally approved for, into broader weight management treatment. So leveraging MarketScan, our longitudinal database, we found that GLP-1 utilization has grown from 4.8 patients per 1,000 back in 2013 up to 55.3 patients per 1,000 in 2023. That's a compound annual growth rate of 25%. Meanwhile, GLP-1 spend is also increasing from $13 PMPY in 2013 up to $265 PMPY in 2023. That's a compound annual growth rate of 32%. In 2022, the average spend per patient on GLP-1 medications was nearly $6,000. Payers are obviously looking for strategies to manage this growing trend and measure efficacy and outcomes of this rising drug class. In order to best create a strategy that manages benefits without interrupting care, we first have to split GLP-1 products into two groups based on their treatment focus, so diabetes and weight loss. Although GLP-1 products in both groups are really similar, often containing the same active ingredients, the effort of splitting our strategy allows us to focus and match benefit offerings, requirements, and outcome measurements to specific patient populations. So starting off with diabetes, products here include Ozempic, Mounjaro, Trulicity, and many others. These products are covered by nearly 100% of payers and have become a standard of treatment for diabetes, slowly replacing older classes like sulfonylureas, TZDs, and even insulin in many cases. The main goal of GLP-1 treatment for diabetes patients is not weight loss, but HbA1c control and better diabetes control. Weight loss, though, is an added benefit and the catalyst as to why GLP-1s are slowly replacing some of those older drug classes as a standard of treatment for diabetes. Payer management strategies for diabetes-specific products includes preventing off-label utilization, lowering socioeconomic barriers for diabetes treatments, and improving adherence and compliance. And so let's walk through some of those examples in the next few slides. So through 2022, MarketScan saw a growing trend of off-label utilization of diabetes-specific GLP-1 products, growing from 6% of patients using these products off-label in early 2022 to 11.9% by the end of 2022. In early 2023, we notified payers of this growing trend, and many of you started placing prior authorizations to help control off-label prescribing. These prior authorizations ranged from requiring a diagnosis, having a history of metformin use, or even sometimes limiting the prescribing provider. We shouldn't see a dentist prescribing Ozempic. While these prior authorizations worked for some populations, others didn't see much of a change. However, and as of early 2023, MarketScan showed only a small dip, down to 11.3% in off-label use. But as more data comes available, we're hoping to see that this continues a downward trend. When analyzing the products that were used off-label and comparing 2022 to 2023, an interesting trend emerged. In 2022, 74% of patients using a GLP-1 off-label were using Ozempic. In 2023, Ozempic was still the most frequent product used off-label at 60%, but its share was cut into by Mounjaro. This trend is interesting because while Mounjaro was available in 2022, we didn't see much off-label use until 2023, while its weight loss counterpart Zepbound was being actively reviewed by the FDA. So if we follow that same trend of diabetes-specific products spiking in off-label use immediately preceding the market approval for weight loss, we should expect to see a spike in Rybelsus use this year, as in 2024, a weight loss version of Rybelsus is currently under active review by the FDA. So surges in these off-label utilization can also cause a lot of difficulties for diabetes patients who need these medications. Next slide. In another study using MarketScan, we identified considerable GLP-1 affordability and accessibility gaps for high-severity diabetic patients. In the study, we looked at the rate of high-severity diabetic patients compared to GLP-1 usage across the CDC's SVI, or Social Vulnerability Index, poverty levels varying percentiles. Those neighborhoods with the lowest rates of poverty on the left-hand side of this graph compared to those on the right-hand side with the highest rates of poverty up in that 75th to 100th percentile. The red line on the graph, which displays the percentage of diabetic patients with high severity or diabetic complications, grew from 44% in low poverty neighborhoods to 52% in high poverty neighborhoods. Because GLP-1 medications have become a preferred drug class for diabetes, especially for patients with high severity diabetes and complications, we expected GLP-1 utilization to follow the same trend, growing from left to right. And we did see this for most of the SVI cohorts, those purple bars. GLP-1 utilization grew from 199 patients per 1,000 for that 0 to 25th lowest poverty rate group, up to 206 patients per 1,000 for that 50th to 75th percentile cohort, so the second highest poverty rate group. But then we saw a really steep drop-off. Despite that 75th to 100th percentile cohort, those neighborhoods with the highest rates of poverty, having the highest rates of high severity diabetics, this cohort had among the lowest rate of GLP-1 utilization. This treatment gap should be a major concern for payers as you think about managing your diabetic population. We know payers are already paying a majority cost share of these medications, but consider how out-of-pocket costs may impact different cohorts within your population, and if there are access and affordability barriers that could be preventing quality outcomes. Next slide. So back to those two data strategy cards for GLP-1 management. Let's next look at weight loss specific products. So weight loss specific products include Wegovy, Saxenda, and the brand new Zepbound that was approved late last year. Unlike diabetes specific GLP-1 products, only about 60% of payers currently cover or plan to cover these medications. Also, unlike diabetes specific GLP-1 products, the primary clinical goal for these products is weight loss, followed by decreasing obesity related comorbidity risk and mitigating advancement of future health risk. Management strategies here include matching a patient with the right treatment for their individual weight loss goals, treating patients in lockstep with nutrition counseling and exercise coaching, and ensuring patients remain adherent to both their prescription and their wellness regimens. As we think about the use of pharmacologic treatment with weight and obesity grows, each payer will need to think carefully about their own population to consider coverage. On one hand, comprehensive weight loss benefit offering that matches patients with a clear clinical goal for weight loss and right sizes their treatment accordingly can not only benefit from health improvement and financial savings, but also be a major recruiting tool for employees and members. On the other hand, proper management of GLP-1s can be expensive, not to mention the GLP-1s themselves. So payers may choose to set aside these medications for benefits, including maybe smaller payers or payers with high turnover rates. Each payer will need to really sit down and think and weigh out the pros and cons and make a decision that best suits their population needs and benefit goals. So for those that plan to cover weight loss GLP-1 products, there's considerable research into the efficacy, outcomes, and best practices for management. 3 weight loss GLP-1 products are now on the market, each with a different weight loss goal and efficacy results. While all of these should be used by patients with a BMI over 30 or 27 with comorbidities, their varying clinical outcomes offer a variety of options based off of a patient's starting weight and clinical goals. As many of you are familiar, patients taking GLP-1s will only continue to lose weight if they remain on the medication. However, studies are showing that even as a patient regains some of the weight after medication cessation, if they continue their wellness regimen, we still end up with a net loss. So we still end up with an improvement and a decrease in weight, meaning not all of their weight is regained. There are numerous studies on the clinical impact of weight loss, and that's the question I often get. For example, patients who lose 2.5% of their body weight can expect to have improved glycemic control and diabetes control. 5% or more of body weight loss should have HDL and triglyceride improvement for like dyslipidemia or a high cholesterol patient. 10% of body weight, loss of body weight can improve knee pain, and so on. These studies offer payers and their benefit partners clear clinical weight loss goals that should be set for patients prior to beginning a GLP-1 medication. Whether it to be to aid in regression of a current condition or prevention of future conditions, patients should understand what their weight loss goal is and the clinical drivers behind it. Similarly, providers and vendors who set these goals with the patient should be matching the treatments with those goals. So as an example, Zepbound, which is known to help patients lose upwards of 50 pounds, might not be the right product selected if the patient is only trying to lose 10 to 15 pounds. There are other products, including those outside of GLP-1, that may better suit that individual's clinical needs. And that matching of the right treatment to the right patient is key to realizing maximal clinical outcomes and financial savings. Studies that have evaluated the real-time savings of weight loss medications record seeing a decrease in healthcare spend between $1,300 and $2,700. However, these findings did not include the medication itself. And unfortunately, due to some of the high costs of some of these medications, that the savings can effectively be wiped out. But real-time savings isn't the only benefit of GLP-1s, right? We know that there are long-term savings due to disease regression and prevention. When calculating ROI or financial outcomes of GLP-1 treatment, it is important to not only look at that real-time change in healthcare spend, but also project the delay or all-out mitigation of these disease advancements associated with weight loss. That's something that we can help you with. So let's get into some of those kinds of examples. So first, we'll want to measure our primary outcomes. So unlike diabetes, where a primary outcome is HbA1c control, for weight loss specific GLP-1s, the primary outcome is weight, or more preferably percentage of body weight loss. And although BMI can be an okay substitute, it's really not ideal. Once we have weight loss outcomes, we can measure both real-time and prospective healthcare outcomes for weight-related comorbidity. Do we see a decrease in healthcare utilization? Based on the percentage of body weight loss, what can we expect in the future of disease and risk mitigation because of that weight loss? And finally, we can summarize our real-time and expected clinical outcomes into an ROI to further support ongoing investment into weight loss initiatives and understanding both the successes and missed opportunities of your current benefit strategies and vendor partners. But all of this starts with the right measurement and data strategy. I can't tell you how many payers I've talked with this past year who want to measure outcomes, who want to measure ROI, but don't have the data or vendor partners in place to truly maximize the management of GLP-1s. All of you are already working with eligibility, medical, and drug data, right? These are the cornerstones to utilization reporting, off-label evaluations, and tracking demographics of who is using GLP-1s. But the largest mistake we're seeing currently with payers is a data gap with biometric and lab data. You've heard me throughout this presentation talk about HbA1c and weight as the primary outcome measurements for GLP-1 medications. Those are our first measures to see if those GLP-1 drugs are working. But most payers don't have a strategy in place to collect this information or aggregate it with healthcare claims data. even those that do collect, say, biometric data on like an annual basis, that leaves far too much latency between when a member starts a GLP-1 and tracking them over time to see if there's efficacy or if there are treatment gaps. Numerous vendors are now, and point solutions are now bolstering their ability to collect weight information more regularly, allowing patients to better track how a patient, payers track how a patient navigates through their weight loss benefits, and if there are gaps or barriers that need to be resolved. This more frequent collection of HbA1c and weight data could be self-reported from the patient, and in addition to like an annual or quarterly collection by a provider. Self-reported data isn't often the most ideal, but having a patient go out and have their like biometrics taken every month or every week is probably also extremely cumbersome. So that self-reported data can be added on top of your annual collection of biometrics. It allows us, again, to more regularly track and then still have that backup that improves the data quality and accuracy of that provider collected data. Other important data types, depending on your unique benefits and vendor partners, include like weight management or program data. So if you were to enlist in a program that collects self-reported weight data, health survey information like readiness for change or attitudes towards nutrition, productivity data that can be added into outcome measurements. So I've covered a lot of topics today around GLP-1s, but your strategy blueprint going forward can really be condensed under the 4 topics you see listed here. First, implement a data strategy. Payers must have a plan on how they expect to measure GLP-1 outcomes. Who are the vendors responsible for management? What are their success measurements? Do we have all of the data elements necessary to accurately measure clinical and financial performance? Second, lab and biometric data are critical. Clinical outcomes lead to financial outcomes. Lab and biometric data are the primary outcome measurements for GLP-1 medications. You must have a plan to collect and evaluate these data types in lockstep with prescription data. Third, identify and evaluate your vendor partners. Set your members up for success. Are there gaps in benefits compared to published efficacy studies? Are your members engaged with nutrition and lifestyle changes in addition to these prescriptions? Are members suffering through side effects that can be lessened with education and over-the-counter medications? Why are members struggling to remain adherent? Are there socioeconomic barriers to treatment? And then fourth, data latency can lead to wasteful spend. Payers must consider how they can quickly respond to member needs throughout treatment. Understanding why a member stops treatment should be analyzed and rectified within days and weeks, not months and months later. Analyzing if members are losing weight should be a monthly review, not just a year-long look back. Latency in reporting treatment gaps will not only lead to less successful outcomes, but also increased wasteful spend for payers. So thank you all for your time today. With that, I'm going to hand it over to Brandy Hodor, who will talk about our next topic, the Benefits Blueprint webinar. It's the clinical journey of cancer patients.
Thank you, Catherine. So I want to thank everyone for joining us this afternoon. As Catherine mentioned, I'm Brandy Hodar, and I'm a Senior Financial Analyst Advisor. I've been working in healthcare strategic planning for the last 25 years, and for the last 13 of those years, I've been here at Merative working with health plans and employers to leverage healthcare data to deliver highly customized strategies and improve health equity. Let's stay on the path of topics that are extremely top of mind for health plans and employers, and that leads us to cancer. The American Cancer Society estimates for 2024 that over 2 million new cancer cases will become in the U.S. alone. When we consider men and women younger than 50 years old, colorectal cancer was the 4th leading cause of cancer death in the late 1990s. But now it's actually ranked 1st for men and 2nd for women. The COVID pandemic caused delays in the diagnosis and treatment of cancer in 2020 because of healthcare setting closures, disruption in employment and health insurance, and fear of COVID-19 exposure. Getting preventative care and managing the conditions that we have all got tossed up in the air, and now 3 years later, we need to circle back to that focus. So let's take a look at cancer patients and see where we stand and what we can do going forward. When we think about clinical journey of a diagnosis, it all starts with that first diagnosis code entered on a claim. And when we talk about cancer, we need to also include prevention in that discussion. According to the American Cancer Society, more people are being diagnosed with cancer than ever before, and at an earlier age. Here you can see we're looking at patients per 1,000. When we look across all types of cancer, we see a consistent increase from year 1, which was the year prior to COVID, to year 2. Skin cancer alone almost doubled in year 2, jumping from 8 patients per 1,000 to 14.5. We also saw significant jumps in both breast cancer and prostate cancer. When we look at year 3, while numbers start to come down ever so slightly, they're still higher in every type, with the exception of lung cancer, that actually dropped to below pre-COVID rates. Remember when Catherine was talking about the GLP-1 drugs, and we looked at neighborhoods by poverty percentile for the 4 quartiles of patients taking GLP-1 drugs versus those in later stage diabetes? Let's look at the cancer utilization rates by that same slice. Here, we are using the CDC's Social Vulnerability Index and overlaying on top the neighborhood information on the claims data. This allows us to understand and see patterns that might be driven by factors at that community level. So let's first talk about areas of higher poverty. They're going to have financial concerns, lack of support systems within the neighborhoods. There might be limited resources. New doctors don't move into these neighborhoods. Grocery stores are moving out. In the comparison, we see lower rates of breast and skin cancer in areas of higher poverty, something we might not have expected. While I would love to tell you that we have a better handle of controlling breast and skin cancer in higher areas of poverty, we know that's not the case. Sometimes you have to look to see what the data is actually not telling you. In these areas of higher poverty, you will also find higher levels of unemployment, a struggle to put food on the table, and even pay everyday bills. These members are likely to work second or third shift. They're caring for aging parents or young kids and tend to care for themselves last, thus postponing that preventative care and that early diagnosis. We need to engage members to be an advocate for themselves by getting potentially life-saving cancer screenings. This allows us to catch that cancer early so we can treat it less invasively and increase survival rates significantly. By using our disease staging coded criteria, we can use our medical episode grouper to slice into over 580 different clinical episode types. Here, let's take a look at breast cancer. Each episode is mapped into high disease stage, ranging from 0 to 3. For this analysis, we look at stage 0, 1, and roll together 2 and 3. Stage 0, those in red you see, include people with a history of cancer. This may include screenings and biopsies that they have done. Stage 1, the purple, is breast cancer is still localized. It may require minor surgery or radiation. And as we move into stage 2 and greater in blue, this starts to include advanced complications with tumor extending to other locations and typically involves expensive targeted therapy. When we look at cost per stage, it's not surprising that as you progress from stage 0 to stage 1 to stage 2, overall costs increase. If we can work on bringing members back to a healthier stage or halting the disease progression, we can improve health, life expectancy, and reduce costs. So let's take a look at our market scan population that Catherine mentioned before. Looking at only members who had a breast cancer diagnosis in both year 1 and year 2 of the analysis, we see 54,000 members across all 3 groupings. 45,000 of the patients, or 84%, were in stage 1 in treatment year 1, with 4,603, or 8%, were at stage 2 in year 1. Of those patients in stage 1 during year 1, over 3,000 of them, or 7%, actually reduced their cancer stage within a year, dropping to that stage 0. For those in year 1 that were at stage 2 and greater, we saw 1,500, or 34%, reduce their treatment to a stage 1. Both cases may point to successful treatment and management of conditions. By looking at the cancer journey of patients, such as from one stage to another, we can also evaluate programs that are put into place and start to pull out the return on investment of these programs. When we think about the cancer journey, like we mentioned earlier, prevention care is a key. Not surprising, early detection is key in lowering cancer deaths and improving the outcome of cancer diagnoses and in lowering overall costs associated with that cancer. Experts still aren't sure why certain cancer rates are increasing in younger adults, but say it could be due to rising rates of obesity and still unknown environmental factors. Mammograms play a key role in breast cancer detection. For the 2021 measurement year, NCQA reported that for commercial PPO, the screening rate was at 69.8%. While that's down from pre-COVID numbers, it is actually a 3.1% improvement from numbers 10 years ago. Another way to combat cancer is by controlling for the cancer risks. Let's talk about those types of risks. There are modifiable cancer risks, which include health behaviors and lifestyle factors. These can include tobacco smoking, excess body weight, alcohol, ultraviolet radiation, poor diet, infections, and even physical inactivity. There are also environmental risk factors for cancer, such as radiation. And some of these, such as workplace exposures, may be modifiable or non-modifiable. For this discussion, let's consider modifiable risk factors. When we look at MarketScan, we see a rate of 71% of eligible members were screened for their mammogram. Of those not screened, 20% had no modifiable risks in their claims data. 9% had one or more modifiable risks. This is both an opportunity for engagement by physicians to target these members to get screenings, as well as an opportunity by payers for targeted communication to members for intervention and programs that are already available to them to help reduce modifiable risks, such as weight management. We need to also consider barriers when thinking about early detection of cancer. When we go back and look at screening rates by the poverty quartiles, we see, not surprisingly, that members that live in less poverty neighborhoods are 6% more likely to have a screening. And again, remember, this is a commercial population. When we start to think about barriers to early detection of cancer, there are multiple ones that a member might encounter. Some of these barriers are specifically overlaid to higher poverty neighborhoods, such as access to care and weak referral systems, as well as fear and financial barriers. This is an opportunity for health plans and employers to step in and engage members, whether it's bringing a mobile mammogram unit to a central location or partnering with wellness vendors that can help provide awareness and education, in turn helping to reduce fear and possibly even language barriers. So what should your blueprint include? You need to better understand your population by integrating healthcare barriers into your analysis. This can be done by linking in publicly available data sets to your medical and eligibility data. There is data from the EPA that looks by census tract at air toxics and lead paint and hazardous waste, and even data from the USDA at a census or county level that looks at supermarket accessibility for healthy foods or food nutrition assistance programs. So there's a lot of data out there available for you. Health equity outreach needs to be key in an approach towards screening for cancer. We need to look to do better in engagement of our populations in preventative care, and that includes all populations. And like Catherine mentioned, data latency is critical. This can impact outreach and engagement for early treatment. Now let me pass you over to Brian, and he's going to discuss price transparency and your 2024 blueprint. Thank you.
Thank you, Brandy. Hello, everyone. My name is Brian Briegel, and by way of background, I focus on federal regulations that impact payers, specifically health insurance issuers and employer group health plans. I've done this for the past 17 years, and for the past several years, almost 4 years, maybe 5 years now, my focus has primarily been on all things price transparency. So we'll talk a little bit about price transparency today, how it's changing in 2024, and how this can fit into your plan's strategy blueprint. First, let's discuss the publicly available data sets, the payer machine readable files. And to use the machine readable files for the purposes intended, they must be accessible, attributable, and accurate. The public and interested stakeholders must be able to easily locate the files, attribute the payer and the providers to whom the rates apply, and trust the data that's in the files. We would note that this July marks the second anniversary for the enforcement of the payer requirement to post the in-network and the out-of-network allowed amount files. The prescription drug files required by the rule had exercised enforcement discretion for those files. So we do anticipate on the second anniversary here some updates from the departments. They spent the past couple of years now helping payers stand the files up, understand the schemas and requirements. But at the 2-year mark, we think it's time for the feedback to be given to payers on schema enhancements and the required standards. Also, any updates on planned enforcement activities. Again, 2 years in, time for some feedback, and there's been some significant enforcement efforts in the hospital side. So it would be good to understand where the departments are at with enforcing this payer side. I mentioned the prescription drug requirement for the prescription drug file had enforcement discretion. In September, the big change is the departments have rescinded that enforcement discretion, excuse me, and the machine readable files, the requirement for those prescriptions enforced, and these are going to advance and move forward. And here's a little blurb when the departments announced the rescinding of the discretion is they had concern initially there might be some overlap with the prescription drug data collection reporting, which is summary reporting for high cost drugs, medical spend by category, very high level annual reporting required by the Consolidated Appropriations Act. We have helped many of our clients at Merative compile those reports, submit them to CMS. We're in fact ramping up to do this cycle, which is due June 1st. And if you've been involved in that, it's very clear and has been clear, there is no overlap. This is very summarized data. The prescription drug machine readable files will expose a very granular level of information about prescription drugs. The pharmacy provider level, including NDC, the negotiated rates, and historic net prices, that is net of any rebate and price concessions. So rebates won't be available in the files, but you'll have 2 data points for financials, the negotiated rate and a historical look back of the net price actually paid for those drugs, again, at the NDC level. It's a significant change for 2020. And we think that as CMS begins to move forward with the prescription drug enforcement, there's been a location for this on the CMS GitHub site to provide technical guidance. As that ramps up, we think it's an opportune time to kind of dovetail and give feedback on the in-network and allowed amount files, again, activity on those files. Next slide, please. So, as we believe that machine readable files provide value in a multifaceted strategy for a price and discount analysis framework. When you consider the machine readable files, they will allow you to understand your claim costs and how they compare to your negotiated rates, as well as to other payers' negotiated rates for the same providers, items, and services. Additionally, being able to establish a baseline to the rates that Medicare would pay via Medicare repricing, for example, of your claim, something that we offer today in partnership with Wakely Consulting for our clients to understand Medicare baseline for the same services in those same market areas, and thinking about bringing in some real-world data, for example, via our market scan reimbursement benchmarks, allow you to bring into focus what are average payer rates for these same items and services in these market areas. How does it compare to what I'm paying under my plan? So we think individually or collectively, these data sets can provide a solid substrate for your price and discount analysis. Bringing them into a health insights system or a similar system will enable informed and objective analysis, providing real insight on your cost, helping to identify opportunities for negotiation in areas that have potential to lower overall plan cost. Next slide, please. So on this slide, we have some examples of services that illustrate significant price variation that can often exist across providers within the same site of service and geography. And because provider costs can vary significantly within the same geography on both inpatient and outpatient settings and services, Medicare repricing of your claim Leveraging that real-world data like reimbursement benchmarks allows you to surface and assess true price outliers in a given market area for items and services. And again, this can help inform discussions with providers as well as identify targeted services or even a market basket approach to cost-saving opportunities for your plan. With a discount analysis and the ability to secure more favorable rates to help bring down plan cost is very foundational and ties in the next area we're going to turn to, which is price transparency for members and how they might bring down their own out-of-pocket costs. Next slide, please. So price transparency for members, the member-facing shopping tool required both under transparency and coverage, as well as under the Consolidated Appropriations Act. Important to give transparency to members in advance of care. On this slide, we have an example of our treatment cost calculator, something that we have provided for over 14 years at Merative to help give members convenient and accurate estimates in advance of seeking care. Some of you may leverage our treatment cost calculator solution. You may work with another vendor, or you may be developed or have developed your own solution in-house. In all cases, the regulatory lift in 2024 is to advance the shopping tool from a limited prescribed item, required list of 500 items and services to open the aperture to allow members to shop for all items and services covered by your plan. And this is a significant lift. So our team at Merative continues to advance treatment cost calculator. It is enabled, for example, to ingest machine-readable files and render the in-network rates to your members in the shopping tool, which is required under rule. In addition, we have curated and bundled service to give more enhanced experience to member shopping to get a more full picture of the care, for example, a knee replacement instead of a specific item-by-item list by way of regulation. We also enhance shopping experience by leveraging claim data to support the negotiated rates when it's appropriate to do so, to give, again, a more custom and shoppable user experience to your members instead of an itemized list to understand their costs in advance of care. So this large expansion, opening the aperture from a list of discrete shoppable services, takes significant time to bring all items and services. It could be thousands, up to tens of thousands of items and services. It could be very overwhelming to the member, but the ultimate goal is to help them be able to shop if they care to in advance of care when they can, and perhaps bring down their own out-of-pocket costs, saving them money, and ultimately, if they pick lower cost providers, saving the plan money as well. Next slide, please. Some things on the horizon coming down the line. We have both on the rulemaking and the legislative front. First, on the rulemaking side, we anticipate, in accordance with the regulatory agenda, to see the advanced explanation of benefit proposed rule in March. This is something that's been in the works for several years now. It is a requirement under the Consolidated Appropriations Act to, again, take the same kind of information that a member shopping tool can provide. But in this case, it's effectively shopping through a provider, where a member presents to a provider, requests a good faith estimate, or they schedule an appointment. The provider then packages the information, diagnosis codes, procedures they're going to render during the encounter, or that are being inquired by the member. The providers then transmit that good faith estimate to the payer. The payer is then required to turn that into an advanced explanation of benefits, what you would see today on an EOB, and give that back to the member in advance of care. So the proposed rule should give some insight and frankly address some concern that the market has shared. There was a request for information to inform the departments on rulemaking, and in the RFI, the departments acknowledged, and so did largely the payer community, vendors, including Merative, saying there is a lot of overlap when you require all items and services to be both in the shopping tool and to be presented in an AEOB. It's duplicative, it's expensive, it can be confusing to a member to have all these things shoppable in a tool. The AEOB seems a better place to have all items and services shopping through a provider, packaging the information, giving it to the payer to do an advanced explanation, adjudication, if you will, on that request or scheduled appointment, and keep the shopping tool limited to a 500 or a discrete list of really, truly shoppable items and services for a better member experience. So we'll see what the departments have to say about that here in March in the proposed rule. We also expect they're going to weigh in on standards. What kind of standards might be required to exchange the information between providers and payers? there is a sense, I would certainly say HL7 Da Vinci Project, patient cost transparency implementation team has been working for years now to FHIR enable this movement of data. So we'll see if the departments will make this FHIR standard a recommendation, or will they make it required for healthcare operations? So I'll be curious to see what's in that proposed rule in March. On the legislative front, we do see, again, more push for transparency. There's a Lower Cost, More Transparency Act was passed in December with overwhelming bipartisan support in the House. And if this is enacted into law, this is going to take some current transparency regulation. It's going to harden it into law. And it's also going to require more transparency via release of machine-readable files and information, specifically lab, imaging, and ambulatory surgery centers will be required to post their payer-negotiated rates in machine-readable files. So a continued drive into transparency that we think plays an important part for you to consider in your strategy blueprint. Next slide, please. So a lot of information very quickly presented and really draws back and say, what is your strategy blueprint with price transparency? Do you have plans for performing discount analysis, leveraging machine-readable files, Medicare repricing, for example, or bringing in real-world data to understand how your rates compare to the market and other opportunities to be identified? The forthcoming release of the prescription drug files, it's not going to happen immediately, but is it on your radar, and should it be on your radar to understand what your rates are you're paying for prescription drugs you've negotiated? How does it compare to other rates? And how does it compare to those rates that have been net of rebates and concessions? Where do you stand? How do your GLP-1 or other expensive drugs and what your plan is covering and paying for, how does it compare to the market? So a very powerful opportunity here in the prescription drug space, and frankly, it's good to see it moving forward. And then, do you have the internal capabilities to tap into this data? Or if not, have you established a partner, vendor, who can join with you, who can render these data sets into analytic-ready files to be used for your plan imperatives? And then last, closing out with a member-facing shopping tool. Again, huge expansion, 500 items and services to all items and services covered by the plan. Perhaps that's better rendered by the AEOB. Let's see what the departments have to say in March. But with that, with the expense you've poured into your tools and open the aperture, how have you activated consumerism? How did it go for you in 2023? What's your strategy blueprint for 2024 moving forward? You have the cost involved here to hopefully get the members saving money, but how do you activate them to come back to the tool, shop the tool, and what's in it for them to actually get an ROI for the investment, both for the plan and for the member? And if you're standing up an in-house solution for a member-facing shopping tool, for example, with this expansion, with the requirements under the regulations, is it time to think about engaging a partner who can help you meet the requirements and go beyond them? And so with that, very short presentation around this, appreciate the time, and I'll turn it back to Manny, to wrap up for us.
All right, thank you, Brian, and thanks to all of our presenters today. I wanted to just provide a very brief wrap up. I think the presenters did a really good job just sort of summarizing each of their points, but to really boil it down to 3 takeaways here. I think what we're hearing is on the GLP-1 front, average spend on GLP-1 weight loss medications, have been on the rise, and the high cost of those medications can certainly drive gaps in care. And so payers really need an effective data strategy to measure those outcomes and set their members up for success. In terms of cancer trends, we are hearing more from clients who are interested in examining the clinical journey of cancer patients in their population. Payers will need to examine the data to understand their own population needs as well as barriers to ensure access to quality care and prevention. And then on the price transparency front, as Brian just stated, CMS is advancing the next stage of its regulations, and payers here have an opportunity to leverage machine-readable files in price negotiations, as well as member engagement, as long as they have the right plan and partner. So, with our remaining time here, about 9 minutes, we'll open things up for Q&A. I encourage you again to please send your questions in using the Q&A button at the top of the toolbar. Before I do that, I did want to let folks know of a few ways to continue the conversation here. Starting off next Thursday at 1 p.m., Merative will actually be launching a series of weekly Lunch and Learn conversations with our experts. And so Brian Briegel, who you just heard from, will be available for about 30 minutes for an open discussion on price transparency. So if you have further questions, you want to dive deeper into that particular topic, we encourage you to please join. We'll be running that series of Lunch and Learns every Thursday, 1 p.m. Eastern for a few weeks. and you'll receive more information about how to join after the webinar. So if you are interested, please do drop in. Besides that, you can always find thoughts and insights from our experts online at our Thought Leadership Library. We're going to drop the link to that in the chat, and there you can read our latest blog posts, white papers, reports, etc., on some of the issues covered here on today's webinar. And as always, you can feel free to reach out to our team at merative.com/contact. But for now, I'm going to move things over to the Q&A panel here. All right. I see a question here. I think I'll direct this one to Catherine. So Catherine, are you continuing to see members who begin GLP-1 medications drop off within 6 to 12 months of starting? And if so, does that seem to be driven by outcomes or difficulty to sustained adherence, such as side effects and costs, etc.?
Talking on mute. That's a really great question. So as you're thinking about when patients are dropping off, looking at the months in which they've been taking the medication is really key. If you're looking within like 3 to 4 months of them starting the medication, that's typically when you see a drop off due to side effects. Usually in about that time, they're starting to have gastrointestinal issues or injection issues, or it's generally in those beginning months. By the time you hit like 4, 5, 6, 7 months, by then most side effects you've either figured out that you need a anti-nausea medication, or by then side effects have lessened because you've gotten used to the medication, you've maybe changed your nutrition or exercise habits that has helped with those side effects. But by that point, it's honestly usually it's outside influences, maybe not necessarily that you've reached weight loss outcomes, but maybe there is an outside effect that is impacting you taking the medications. Maybe you have a new diagnosis. Maybe there is financial barriers to continuing the medication, but there's usually some kind of outside influence that's causing the drop then. Once you start to get to like 9 months plus is when you start seeing drop-offs due to outcomes. Most of the clinical studies on these medications ranged from 40 weeks, I think, all the way up to like 84 weeks, step 2. And so let's just take the low end, 40 weeks. You're not even hitting a year at that point. But obviously, every patient's going to have their own unique and weight loss goals. But it's usually in and around like 9 months plus that you're starting to see people hit those weight loss goals and stop medication because they've achieved those goals, and then just continuing with nutrition. Now, again, we see some weight gain with that, so we do want to, expand continuation so that even when we regain weight, we're still within those clinical weight loss goals. But that's generally so a little bit more granular than just 6 to 12 months, but I hope that helps.
Yeah, I appreciate that, Catherine. Thanks so much. And I think this one's for Brandy. I'm going to ask about the publicly available data. How do you find publicly available data? And are there any cautions with working with that?
Yeah, absolutely. So when we start to think about the publicly available data, a lot of different agencies publish this data out on their websites. For the example of the CDC, if you type in CDC and SBI, it'll give you a wealth of information. Something to think about as you're working through this data. Some data is at a census tract level, so you may need to geocode your addresses and provide that information in there. Some of it's at a county level, so you want to make sure you're aware of what level of information you're working with and how old that data is. Some of the agencies update their data every 2 to 5 years, depending on which agency we're looking at. The CDC, for example, with releasing their SVI data, it actually got delayed because of COVID. So the 2020 data was actually not released until about October of 2022, and we're still waiting for the next update. So definitely there's a lot of wealth of data out there. For those that are Merative clients, we actually have a process where we can help you to load this data into your warehouse. So it is then side by side. So the analysis like you saw Catherine do and some of the data like I showed you, you can actually run that then on your own data. And we do have quite a few clients already that are bringing this data in-house and working with it actively.
Excellent. I appreciate it, Brandy. I saw a note that folks might have had some trouble answering our poll question. Just as a heads up, if you head to the toolbar at the very top there, there's a button that says polls. It is still open, and if you haven't already provided an answer, we really would appreciate it. If you have already answered, then thanks for doing that. But still time here in the last few minutes to submit a poll answer if you haven't already. I guess last question here for Catherine. Just kind of a broader question, but the future of GLP-1s, obviously this has been in the news quite a bit over the past year. Doesn't seem like it's going away anytime soon. I guess from your perspective, what's coming next?
Yeah, so I talked a bit about this. I kind of alluded to it, but I didn't really get into the details on this. So I kind of mentioned that some of these medications are going to start coming off patent. Probably in the next 2 years, we're probably going to see Victoza, Trulicity, and Saxenda coming off patent by like 2026, or even before. And so when those come off patent, making sure obviously generic strategy, utilizing those where possible, but there's going to be probably opportunities for step therapy for, again, matching patients to the right treatments. On the other side, in terms of approvals, I kind of mentioned this in terms of a weight management product similar to Rybelsus. There is going to be an oral, probably approved this year, an oral weight loss product for GLP-1s. Right now, there is one oral product for diabetes, the Rybelsus. They're very likely this year, like I said, it's under active review by FDA right now. I don't know the product name, right? It's not released, but it's likely going to be reviewed. And so an oral weight loss product is probably going to, we're thinking it's going to really greatly, I mean, if you already think that patient population has increased, most of the weight loss or all of the weight loss medications right now are injectable. So as you all are well familiar, injectables can pose a significant barrier to patients not wanting to take an injectable. And so now there's going to be an oral option. So we anticipate there's going to be another spike in utilization because that oral option is going to give more patients access to a weight loss option that they are comfortable with taking. And so just kind of preparing patients or members for that.
Excellent. Appreciate that, Catherine. So that brings us right about to the top of the hour. So we're going to go ahead and close this one off then. Thanks again to our presenters for the great content today. Thanks everyone for attending. And as a reminder, if you are interested in learning a little bit more about price transparency, we'll be meeting next week, 1 o'clock Eastern time. Brian here will be here to answer your questions. So again, bring your questions and we'd really love to hear from you. So thanks again, everyone, for joining and have a good afternoon.